Did you know that many children are told that their asthma is controlled even though it isn't? One way that healthcare providers check to see how someone's asthma is doing is by using something called a validated asthma questionnaire or tool. And today we're breaking down the research behind a new validated questionnaire, the Peds-AIRQ. This is designed for kids ages 5 to 11, and it looks at both symptoms and past asthma flare-ups. And we talk about why that difference matters. This podcast is made in partnership with the Allergy and Asthma Network. We want to thank AstraZeneca for sponsoring today's episode. While they support the show, all opinions are our own and sponsorship doesn't influence our content or editorial decisions. Any mentions of brands is for informational purposes only and not an endorsement. Now let's get to it. You're listening to The Itch, a podcast exploring all things allergy, asthma, and immunology. We've got our first journal club for you guys this year, and we are talking about the paper Pediatric Asthma Impairment and Risk Questionnaire, Peds-AIRQ, a control assessment for children aged 5 to 11 years. This was published in July 2025 in the Journal of Allergy and Clinical Immunology in Practice. And today is the first time we've ever done 4 people on our podcast, so we're excited to hear how that dynamic is going to be working out. And with us today is, as usual on our journal podcasts, Dr. Blaze and our special guest, Dr. Murphy. Dr. Blaze, I will hand it off to you for the intro.
So it's really exciting to have Dr. Murphy here with us today. He's one of the most outstanding allergists in the United States in Omaha. He's the first author, in fact, of the paper that we're going to discuss today. So I'm going to let Kevin give us his credentials so that everyone can know about him today.
Michael, thank you. And I very much appreciate the opportunity to be here this morning. I did my training at National Jewish a number of years ago and have been in Omaha since, presently at the Boys Town National Research Hospital, which really specializes in the care of children. I'm director of clinical research, both allergy and pulmonary. I have a very special interest that we're going to talk about today, and that's 1, pediatric asthma, and 2, the importance of assessing asthma control in children with asthma. So thank you very much.
Thank you so much for being with us. So can we start off with what was the objective of the paper that we're reviewing today?
Well, first, as we all know, asthma is the number 1 chronic disease in children, and it's the leading cause of missed days from school, emergency room visits, and hospitalizations. And so, based on that burden of disease, we took on the objective to validate an asthma control tool. Most importantly, though, is to validate a asthma control tool assessing both impairment, which, as I tell people, is current symptoms, and then risk, which is the past, and that's past asthma attacks, as our patients refer to them, or we as clinicians call them exacerbations. That was the objective of the paper as we undertook what we wanted to be a very simple tool that could be used by all clinicians for the assessment of all patients with asthma.
As you said, Dr. Murphy, asthma is a very common chronic condition in children, and about half of these children actually don't have their asthma well controlled. And uncontrolled asthma can lead to flare-ups, missing sports activities, worse quality of life, and more doctor visits and hospital care can be required, which affects the whole family. And of course, asthma can also lead to even more poor outcomes, including death. And so we really need to help kids do better, and doctors need to correctly identify which children have uncontrolled asthma and keep track of how they're doing over time. The reason that we have these questionnaires is really to help patients give us a better understanding of how they've been doing, how their asthma has been doing, so that we as doctors, as clinicians, can change our management plan accordingly and make sure that their asthma is truly controlled.
I couldn't agree with you more. I think that was an incredible description of the burden of asthma in children. You mentioned one of those is that the amount of children who have uncontrolled asthma, and I would also comment the large percentage of children in the United States who require frequent courses of oral corticosteroid. So we thought it would, because of this burden, it was important to identify and address what we referred to as an unmet need. And that was to develop an asthma control tool, an assessment of asthma that really looked at, as I mentioned, two aspects of asthma control: present symptoms, how are patients doing today or over the last few weeks, and then what was their past like? Were they having reoccurring attacks, emergency room visits, hospitalizations, need for oral steroid? What we found was that there were no tools available to physicians and families that looked at the complete assessment of control. And of course, as you mentioned, there are consequences if you're not assessing both present symptoms and past asthma attacks, because what happens is you overestimate control and you miss children who are really suffering, going to the emergency room, requiring oral corticosteroids. So our goal was to develop the best assessment that included both what we refer to as impairment and risk. We wanted to do that in a diverse population of young children, but then to bring it full circle to have a tool that could be used, as Michael's very familiar with and involved with, and that's shared decision making when we see patients clinically in the office and care for them, especially patients who have asthma that is really affecting their life and the life of their family.
Thank you so much, Dr. Murphy. So now that we have a better understanding of why this tool is being developed, Dr. Blaze, can you tell us about what was being looked at?
Sure. So if we look at today's paper, it really asks a very simple but yet powerful question. And so what Kevin has been talking about and what's described in this paper is the development of a tool here for a child with asthma, and not only how they're doing now, so their symptoms now, but how risky is their asthma? What is their risk of future exacerbations? So if we look at this study in detail, it included 399 children, and they looked at children between 5 to 11 years of age with doctor-diagnosed asthma, along with their parent and caregiver. Now, these families were enrolled from one primary care center and also from 7 specialty clinics across the U.S., and the study was done between October 2023 and July of 2024. Now, the families here gave their consent, the children gave age-appropriate agreement, and the study followed, again, the important strict ethical and safety guidelines. And a parent and caregiver had to take part with the child, and it had to be the child's main caregiver to participate in this study. So these were children that were actively treated for asthma at the time that they participated in the study, meaning they had to use at least one asthma medication in the past 6 months. Very importantly, the families needed to be able to understand and speak English or Spanish so they could accurately, again, answer the questions. Now, there were a few exclusion criteria to be part of this study. So they did not include children if they or their caregiver had medical, hearing, vision, or thinking challenges. It would make it hard for them to, again, to understand the questions or give informed consent to do the study. Also, children were excluded if they had any other type of lung or medical condition that could look like asthma, because obviously that would confuse the results that were obtained. And lastly, babies that were born, again, very early, premature, before 35 weeks of pregnancy were excluded, because we do know that early prematurity can affect lung health in ways, and again, that may affect the results of the test. Very importantly, this study was designed to really reflect what's going on in real-world asthma in children in the United States. So it included children, again, as we mentioned, ages 5 to 11. There was a range of asthma severity from mild to severe. When you look at the families here, they came from diverse racial, ethnic, and socioeconomic backgrounds, including, again, very importantly, they had an underserved community clinic. So again, to get that population. And up to a quarter of the children had had a recent asthma flare-up.
Thank you, Dr. Blaze, for clarifying who was involved in the study. You had 399 children. They were ages 5 to 11, and they had to have a parent or guardian involved in this study. So the kids weren't the ones answering the questionnaires on their own, basically. So this is an assessment tool. And can we talk a little bit about what that means? What is an assessment?
So, assessments are tools researchers and healthcare providers use to check to see how a child's asthma has been doing over the course of a particular period of time. And so, Dr. Murphy, can you go through and tell us how the pediatric AIRQ was developed?
Yes, thank you first for nicely defining what we do in assessing patients, particularly patients with asthma, in regard to their asthma control. What we did is we had previously developed an asthma control tool referred to as AIRQ, Asthma Impairment and Risk Questionnaire in patients 12 and above, so adolescents and adults. And so we had a validated tool that we could work from as then we developed the pediatric version. One of the very important aspects in the development of this tool was that we wanted it to be simple and easy to use and to remember, even though we were patterning this off of the AIRQ used in adolescents and adults, remembering that children are not little adults. And so we really wanted to be very cognizant and careful in regard to how the children were assessed. This was done in two phases. The first is what we refer to as a cognitive interview, and it's unique and important because before we started the validation, we interviewed 60 what we referred to as dyads, and that was the child and the parent and the caregiver. And these interviews were very important because we had brought to them possible questions that we thought would be important medically, what we thought, based on the literature and our experience, would be important, as you said very nicely, to assess the patient's asthma control. But we included the child and the parent and the caregiver to review these questions to make sure that they were clear, understandable, and important to them. And so what came of that was 18 questions. And as part of that assessment, these were questions that were designed to be understood at a fifth or sixth grade reading level. And so these were questions that could be used across all populations. Then what we did is we had an initial visit. And as you said, there were 399 patients that were evaluated. And at that visit, both the parent, child, and caregiver were involved, as well as the physician. The child, parent, caregiver answered a number of questions. First, the initial 18 questions from our cognitive interviews with parents, caregivers, and children. They also answered important demographic questions. And then they filled out the current childhood asthma control tool that's used very commonly presently when we started the study. And then finally, they filled out a pediatric quality of life questionnaire. Then the physician, as a physician would ordinarily do, they would see the patient, review the history, ask important questions, do an exam, and then they would ask what we refer to as 4 GINA questions. These come from the GINA guidelines, and they assess impairment, which is current symptoms. These symptoms are over the last month, but they ask questions about day and nighttime asthma symptoms. They ask questions about what we refer to as exercise intolerance, and most importantly, what was asthma affecting their day-to-day activity. Those are important questions for impairment that the physicians would ask. And then finally, at the end of the visit, the physician then would, based on their information that they obtained at the visit, they would then rate the patient's asthma control. And that's the background of how we developed and assessed patients' asthma control.
And just for our audience, GINA essentially is the Global Initiative for Asthma. And it's a group of individuals that come together and create guidelines for asthma. And so these guidelines are very important in how doctors and other healthcare providers manage asthma. They're what we use as healthcare providers to make sure everyone's on the same page in how we're managing asthma. We're using research-based protocols in caring for our asthma patients. And so that's what we're talking about when we're talking about the GINA guidelines. And when we talk about validation, we're talking about where we're using a research protocol in order to make sure that these questions that we think will help us assess somebody's asthma control really, in fact, do help us assess somebody's asthma control. It's just a way that we make sure that the tools that we're using are actually helpful for our patients.
Thank you for clarifying that, Dr. G. So when you hear validated tool, you know that there is some science behind it. So you can be more picky about what you are answering if you are a patient looking out there, because I know that you can find most of these tools online now. And thank you, Dr. Murphy, for explaining how you got there, right? So the steps that you were talking about were, how did you find these 18 questions that you are going to be asking patients? And I guess before I jump ahead, Dr. Blaze, can you walk us through what they did when they had these 18 questions to where they got to with the pediatric AIRQ?
Yeah, so what they did here, they really needed, and the researchers, and Kevin can discuss this more, need to figure out, which of the questions really mattered. I mean, they started, as we mentioned, with these 18 draft pediatric AIRQ questions. And what they need to do, very importantly, is get that number down to the ones that just really mattered. Again, very importantly, also to get the questionnaire shorter to make it easier for parents, caregivers to do the questionnaire in an office setting. And so they wanted these questions, the ones that really best separated the kids that had well controlled asthma from those that were not well controlled. And then which questions best identified the kids that had very poorly controlled asthma. So we want to look at being able to separate those three groups. So they didn't use just one statistical model in this particular study because the questions behave differently depending on whether you're trying to identify kids that are really truly well controlled or kids that are really at the highest risk, very poorly controlled. So they used two separate models here, which is the same approach that the group that put AIRQ together. Again, that was the questionnaire, as Kevin mentioned, that was developed for teens and adults. So they looked at different symptom cutoffs. They adjusted for things like age and the demographics, and they compared short-term versus long-term flare-up history. And in the end, they kept the questions that added meaningful information and dropped the ones that were really just kind of repetitive. So once the questions were chosen, then they set score cutoffs that balanced the accuracy from the real-world use, prioritizing not missing kids who were doing well, but also making sure that they picked up all the kids that had very poorly controlled asthma. So again, they want to be able to clearly identify the different groups. Then they compared the pediatric AIRQ to other tools. Again, this is part of, as Pyle was mentioning, part of the validation process. So they compared it to other tools and, in fact, physician judgment to see how well it really performed, and confirmed that it did work very consistently, no matter how the questionnaire was completed. So whether it was paper, pad, etc.
Okay, so it sounds like you had these 18 questions and you needed to figure out how to get from 18 down to something that's a little bit easier to do in clinic and not completely overwhelming. Dr. Blaze walked us through some of it, but just so I can understand once again, how did you decide which questions were actually the ones that you wanted to keep? I know that originally you talked a lot about how you had the doctors evaluate the patients and you had the patient's parents evaluate them using the different validated tools. But how did you take that information and narrow down the 18 questions?
Thank you, because that's very important, particularly as you said, we wanted something simple and easy to use when we're seeing patients and evaluating their asthma. And as Pal said very nicely, we need to have something that's been shown to be validated. So the first step was to develop what we refer to as a criterion, or some people would say the gold standard of asthma control. We then validated these questions against the gold standard, because if we had this criterion that allowed us to define the best questions that clearly and statistically assessed asthma control. And so that criterion included both impairment and risk. And it also, as Michael commented, it looked at the three levels of asthma control: well controlled, not well controlled, and very poorly controlled. And so we used, for the impairment aspect, the 4 GINA questions that we've previously talked about. And that was the impairment aspect. And they were ranked 0 to 4. And so if you had a 0, you had none of those impairment difficulties, then you were well controlled based on impairment. If you had a score of 1 to 2, you were not well controlled. and a score of 3 or 4, you were very poorly controlled based on impairment. Then we included, as you've talked about, the important aspect of assessing asthma control, and that's risk, and that's past asthma attacks, past need for oral corticosteroid, emergency room visits, or hospitalizations. So then we could come up with 3 levels of control that were the gold standard, were decided by multiple experts that this was the criterion to then assess our 18 questions. And so then what we did is statistically evaluated the 18 questions using, as Michael talked about, 2 models. The first model was the comparison of well-controlled asthma to uncontrolled. And so with these questions, would they validate patients who were well-controlled and those that were not? And then the second model, which was important, was to assess patients who had very poorly controlled asthma compared to those well-controlled and not well-controlled. And so then it allowed us to assess 2 important categories, if you will, of patients who were controlled and those who were very poorly controlled. And so what we found was that as we went through these questions, some of these did not have what we referred to as statistical significance. They did not validate, they were not questions that you'd want to ask that really gave you a good assessment of control. We did look at those questions that were meaningful, and we arrived at 8 questions, 3 that were risk-based, previous asthma attacks, and then 5 questions that were impairment. And what we found in looking at both models, that this was a very accurate test. And there's some statistical measures that you can use that are referred to as area under the curve that look at both sensitivity and specificity of an assessment of a tool. And we found both for assessment of well-controlled asthma that this was an excellent tool. And then we also found for the assessment of very poorly controlled compared to all others was also an excellent tool. We were able to draw questions from both models, those that just looked at well-controlled and very poorly controlled, and then came up with 8 questions that could be then, as we refer to it, as point of care, that you could take these 8 questions into the exam room, whether it's on paper or a tablet, and really then in a very, as Payal said, in a very validated fashion that's simple, easy to use, could assess asthma control.
Thank you so much. So I'm just going to summarize that really quickly. So what we're looking at is that when research looked at these tools and compared them, they found that when they're only looking at the symptoms, that these tests really overestimate how controlled someone's asthma is. And when we looked at the 18 draft questions and narrowed them down to the ones that best identified real risk, like frequent symptoms, rescue inhaler use, steroid, or urgent care visits, what I also found helpful was that we looked at a 12-month span of time as opposed to just 3 months. And the reason that that's so important is because asthma flares depending on why you have asthma. If it's allergic asthma, if it's viral induced asthma, it can look different at different times of the year. So if we only look at 3 months of the year previous to your visit, your asthma might look really great. But if we really look at that 12-month span, then we can really see that your asthma really hasn't been doing as well as we want it to, because we don't want any oral corticosteroid use. We don't want any emergency room visits. We really want and are able to, if we have you on the right treatments, keep you out of the emergency room and keep you off of those oral corticosteroids. And that's our goal. And so looking at that 12-month period and looking at those particular questions that identified the risk were very helpful. And then the final pediatric AIRQ that was settled on has 8 questions. When we looked at those, like Dr. Murphy mentioned, they really performed well in identifying and making sure we didn't miss any of those patients that had uncontrolled asthma. So this particular tool helped us identify more patients that were truly not doing well, as opposed to some of the other tools that we had historically been using. So Michael, can you delve a little bit more into the results? I kind of just briefly reviewed them, but for people that are listening that want a little bit more meat, could you review some of those results?
So, as mentioned, the goal here was to develop a simple and easy questionnaire. So, they developed, as we've heard, the 8 questions, And instead of using a scale that we see in many of these control tests, rating it for mild, maybe through severe for a particular question, each question was answered either just yes or no, with a yes answer meaning that the patient was having some type of symptomatology or maybe some type of flare up, again, a symptom of their particular asthma. The higher the score, the poorer control of the patient. So again, the score scale was from 0 to 1. And those were patients that had well-controlled asthma. From 2 to 4, those were patients with not well-controlled asthma. And the group from 5 to 8 had very poorly controlled asthma. And if we look at the results of this study, on average, the children scored a 2.4 out of 8 on the Pediatric-AIRQ. So again, the average here put it into the not well-controlled category. When you look at the score cutoffs, though, what they show was about 40% of the children in this study were classified as well-controlled, 40% were not well-controlled, and 20% were very poorly controlled. Another thing I think here that was important in the results is the tool worked the same in those underserved clinics as we saw on the other sites. It performed consistently here with different pediatric populations. Now, the most common yes answer was in fact having either an emergency department visit, an urgent care visit, or an unplanned doctor visit for their asthma. And that was reported by 44% of the children in the study. And the least most common yes answer was hospitalization, which was reported by 4% of the children. Now, the pediatric AIRQ scores closely matched, again, the measures of asthma control that were seen in other studies. In fact, there was a very strong agreement with symptom tests like with the childhood asthma control test. And if we look at the GINA guidelines for control, and there was moderate agreement with doctors' assessment, and there was meaningful links to quality of life scores for both the parents and the children. Now, the asthma control worsened in the pediatric AIRQ. Scores consistently increased across all these measures. And the relationship with the real-world risk they found was very clear. Only 21% of the children classified as well-controlled had a flare-up in the past year, but this jumped up to 55% in the not well-controlled group and 79% in the very poorly controlled group. And the children rated as not well-controlled were about 4.5 times more likely to have a flare-up, and those rated very poorly controlled, in fact, had more than 13 times more likely to have a severe flare-up compared with those well-controlled children. Now, when predicting flare-ups, the pediatric AIRQ performed better than the childhood asthma control test and slightly better than doctors' assessment. Importantly, they saw that the pediatric AIRQ was much less likely to label children as well-controlled when they actually experienced recent flare-ups, compared to both physician judgment and symptom-only tools that we've talked about. So the bottom line here was that the pediatric AIRQ aligned better with real-world asthma risk. It did a better job at identifying which kids were truly controlled and which ones were at risk for having a serious asthma flare-ups.
So, Michael, that was a terrific review of the findings. And I think that what stands out is that we don't do a complete assessment of a patient's asthma control unless we include both impairment, present symptoms, and risk past asthma attacks. The other thing that stands out is that this simple tool performs better than a physician's general assessment of asthma control, where they're gathering multiple things from the chart, and it performs better than the childhood asthma control tool. And so I think those things really came forward, that we now had a tool that was simple, validated, and easier to use and better than our present tools that we're using in the care of patients with asthma.
I really love the objective nature of these tools because it really allows us to have a way of identifying patients that may need more support. And I think, especially for our primary care colleagues, it's very helpful to have something that's more objective. Even as specialists, it sounds like we need more help too, because a lot of the clinics that these patients came from were from the specialty clinics. And still, what you're saying, Dr. Murphy, is that what the physicians thought was controlled truly wasn't controlled, and that these patients, as Michael pointed out, the results had very high risk of asthma exacerbations, the ones that were poorly controlled according to the Peds-AIRQ. And so it's just nice to know that we have a tool that can help us better identify these patients so we can quickly react and change management of these patients so that they don't have those exacerbations, right? So now we really need to shift the tool that we're using to assess our patients. And that always takes time. But I think having podcast episodes, having more noise out there really helps so that clinicians change what they're doing in practice.
I'm sitting here as a patient and not as a doctor. And what I really appreciate from this discussion is how you've worked to create a very simple tool that patients won't get overwhelmed with. Because I know that sometimes you get to your doctor's appointment and it can feel very overwhelming. You can miss key information. Sometimes what's really bad in your mind is actually not so bad, or what you think is not so bad is actually quite a warning sign for doctors. So I really appreciate that this is a simple, short questionnaire and it's yes or no. Because the worst is getting a scale of 1 to 5 and you're like, well, is it a 4 or is it a 3? And you get caught up on these nuances. But if it's yes or no, and I think for a parent, that's even clearer because they don't really know what's going on inside their child exactly, but they can see something that's yes or no. So I just wanted to jump in there and say, as a patient, I really appreciate that you guys are creating these very clear, simple tools to help assess how well the patient's asthma is doing. And with that, I know that we want to get into some more juicy questions because we have you with us, Dr. Murphy. So I'm going to hand it over to Dr. Blaze.
Kevin, one, congratulations to you and the co-authors. I know that putting these types of questionnaires together and doing the validation is an awful lot of work, and you and all the co-authors should be congratulated for it. I had a couple of questions for you that I thought were important when I was reading through your paper. And one of the things I wanted to ask is, is it fair to label a child with an exacerbation that didn't require steroids, so say 11 months before they did the pediatric AIRQ, and woke up, say, once in their sleep from asthma in the last 2 weeks, is being really a not well-controlled child if, in fact, they've had no symptoms for several months? So my real question here is, compared to the other questionnaires out there, is this questionnaire over-labeling children with not well-controlled asthma, especially if they've had an exacerbation, say, in the last year, but it didn't require, say, a steroid burst?
So important question, because we need to be careful in over-labeling uncontrolled asthma. So I'm going to talk about two aspects of that. So I think we would all agree that if a child in the last year has required oral corticosteroid, that's a red flag. That really is someone who has uncontrolled asthma. The way the question is asked is in regard to the need for oral steroid for worsening asthma or an emergency department visit or hospitalization. So your patient who did not require oral steroid had increase in asthma symptoms, but did not, as we define as an asthma exacerbation, that patient would not score a yes answer to the exacerbation because there was no steroid required. And that patient was having an increase in symptoms. That would be a score of 1. So that patient would be classified as well controlled. I think what's important about this tool, and I mentioned this before, is that we can have a shared discussion with the family as we look at their answers. Because I think all of us, if we had a child who was having nighttime awakenings from asthma but was not having any other symptoms, you'd really want to dial down on the history to really see if that's true, and then make some decisions about whether you clinically thought that nighttime awakenings needed to be further evaluated and assessment. So the score really helps you, and was commented on, this is very easy for patients to do. They can fill this out within a few minutes. I think the other aspect is that what we find in doing the validation is that patients who have a score of 5 or greater, that is very specific. That really gives us a true estimate of patients who have very poorly controlled asthma. And it's really the patient that we can really concentrate on in looking at their care so that we can improve their asthma control. I'd lastly say that I think that Kyle nicely described the importance of this tool, both for specialists, but for our family physician colleagues who are very busy, take care of a number of different diseases diseases, that they have a tool in front of them that is easy for their patients to do, and it gives them a direction immediately in regard to the assessment of control. As you, Michael, talked about, patients 0 to 1 have well controlled, patients who have 2 to 4 yes answers not well controlled, and then especially those patients 5 and greater who have very poorly controlled asthma.
Her paper was a cross-sectional validation study, but it wasn't a longitudinal outcome study. So the pediatric AIRQ is being validated, as you've talked about, against prior events, but not really future risk. And therefore, my concern is the tool's ability to predict exacerbations prospectively is assumed, but it's not proven. And this limits, I think, some of the claims as far as the tool being able to predict risk, despite language suggesting in the paper risk assessment. So I wanted to hear your thoughts. And also, is there a plan to do a longitudinal outcome study with this questionnaire?
So the tool is, as you really nicely said, assesses present asthma control, point of care, looking at present symptoms and past risk, so previous asthma exacerbations. And so it's a current assessment of asthma control and allows us to define well controlled, not well controlled, and very poorly controlled. In the AIRQ, we have done that prospective study and found that in adolescents and adults that the AIRQ was very predictive of future exacerbations, and especially in patients with very poorly controlled asthma, score of 5 or greater. You could sit with your patient and say that they have a 5 to 6 times the risk of having an exacerbation of their asthma in the next 3 months compared to somebody who's well controlled. We are looking at that with the pediatric AIRQ. We think that's very important as the next step. And we are analyzing that data, getting ready to present some of that data, and I think important to present that data. My hope is that the pediatric AIRQ, and I don't have any reasons to think differently, will perform in the same manner as the AIRQ. It allows us to have point of care identification of asthma control, but then to have the conversation with our families, whether they're at risk for future asthma exacerbations. And so I appreciate you clarifying that, because the data, this paper and the data we have presently does not tell us about prediction of future asthma exacerbations, asthma attacks.
Well, what I understand of the existing AIRQ for adolescents and adults is that it is a great predictive tool, and that it does allow us to really know who are those patients that are going to do poorly in the future. And it sounds like, Dr. Murphy, you are planning on looking at the data and these patients to see if, in fact, the Peds-AIRQ also does predict their future risk of exacerbation. So even though technically this is giving us the information at that point, we know as asthma specialists that the past history is so important. And that is a very important factor in understanding what we need to do with these patients moving forward. For me, any patient that's 2 and above, I'm looking at more closely. And then any patient that's 5 and above, I'm definitely making changes in their treatment plan and making sure that we're doing follow-up frequently in order to make sure that they stay out of that emergency room and hospital.
Is this something that patients should be doing without their doctor's guidance, or is this something that you would appreciate a patient not getting into before you talk to them about what it means?
Thank you for mentioning that. We do have a website, airqscore.com, and that it's available for everyone. And that was one of the important goals. Like some of the other tools, they're not available for everyone, but this is online, and this is available for parents, for patients, for physicians, for pharmacists, for anyone who is affected by this chronic disease. And we encourage anyone to go online and look at the AIRQ and take the AIRQ questions. And I think, as Pale said, and I really think that we're trying to make noise about this because it's so important. And so that's why I very much appreciate the opportunity to be with you today, because podcasts and other ways to reach both patients and physicians really, I believe, will improve the care of asthma for all of our patients.
Thank you so much. And we'll link to that. I've taken it with a fictitious child in mind. I've taken it just to see it. And it's really, really, really nice to do. It's really beautifully designed. So kudos to you, Dr. Murphy, and your team. So with that, do you have any final thoughts that you can share with us about the Peds-AIRQ? And I'll get words from all of our doctors real quick. So Dr. Murphy, let's start with you.
Well, I think that from this podcast, we've talked about a lot, but the assessment of asthma control needs to include both symptoms and risk, past asthma attacks, and that we've shown that doing that is superior to the present tools that assess asthma control, particularly in children. I think that what is exciting to me is it allows us as physicians to go in the exam room and have a conversation with the patient that they've already started to become involved with, and that's their asthma control. It's very easy to use, it has pictures, and it really is an example of what we like to refer to as having a discussion with the patient and involving them in the care, particularly the care of their asthma.
For me, I think asthma is oftentimes minimized by patients and physicians alike. And so I really, again, love objective measures that can help us identify those patients that need more care and that deserve to be better managed. And so I think that this is great. And I also hope that our ER colleagues will use this tool and helping them. I mean, I know they're at that point where they see the patient's doing poorly, but I think having that number will hopefully ignite something within them to make sure that they're truly getting to a specialist or somebody else to manage their asthma. So I think it's a great tool. I think that we've always known that past history and exacerbation history is very important to assess for, and this just makes it more objective. And I'm also really glad, Dr. Murphy, that you included underserved communities because oftentimes they're not included in these studies. So I'm really glad that we have that data and that this questionnaire was easy to also use. So I'm really thankful that you guys included that group.
So I think this is extremely important. I mean, if you look at the statistics and you look at emergency department visits and hospitalizations for children with asthma, say over the last 10 years, it hasn't changed. We know so much more about the condition, but yet our outcomes are not improving. And so a tool like this, where it's easy to use, that again, we can get quick information and say, gee, this patient really isn't doing as well as I might think from just listening to their chest. And maybe I do need to do something else to try to prevent them from having their next exacerbation. So we need tools like this to hopefully do a better job so that we can improve those outcomes for those children suffering with asthma.
Thank you so much, Dr. Murphy, for joining us. This was the first time we did 4 people on a podcast, and I think it went pretty well. If you guys want to follow along or you want more information, remember we always have an infographic for our journal podcast, so you can check that out in the show notes. And again, we'll link to the Peds-AIRQ if you want to take it yourself. So thank you so much, everyone.
Thank you for listening to today's episode. Remember that all information you hear today is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. And also, don't forget to subscribe to our podcast. And if you have a second, help spread the word by rating our podcast and sharing with your friends and family who might also be interested in learning more about allergies, asthma, and immunology. You can always stay up to date by checking out our Instagram, The Itch Podcast, where you can leave questions you are itching to know, or check out our website, which is www.itchpodcast.com, which contains more information about the subjects we covered in today's episode and every episode. Until next time, have a fabulous week.